So another lecture that I gave at the plenary session in the meeting yesterday was a session dealing with using genomic classifiers to predict loco-regional recurrence of the tumor. And the background of this is that we developed several genomic classifiers. Some of them are commercially available, but the main goal of these classifiers when they were developed is to predict risk of distant recurrence and also to determine whether patients needed adjuvant chemotherapy or not. And it was mostly developed in patients with estrogen receptor positive, HER2 negative tumors. In the process though, we were able to identify that these predictors also predict risk of loco-regional recurrence. In other words, recurrence in the breast, chest wall, or in the axillary lymph nodes. Because loco-regional recurrence and distant recurrence are very tightly correlated. So whatever factors increase distant recurrence, they also increase loco-regional recurrence. So as a result, we're able to look at several data sets and determine that some of the genomic classifiers that we use for prediction of distant recurrence also predict loco-regional recurrence. Now the question then you ask is, does this have clinical implications? Can we use this? And there are two aspects of this. You potentially use it to perhaps change surgical approach. But in reality, genomic classifiers do not change surgical approach because the surgery for breast cancer is determined usually by the extent of the disease. You know, if there's bigger tumor, you have to do bigger surgery, you have to do mastectomy. So far we haven't been able to identify a predictor where we can change our surgical approach, short of course, putting the patients through neoadjuvant chemotherapy and then shrinking the tumor and do less surgery, as we discussed in the management of the axilla lecture. But the other aspect of that is that you perhaps can tailor radiotherapy to the breast or radiotherapy to the regional lymph nodes. And there have been several data sets indicating that indeed these predictors of distant recurrence predict risk of loco-regional recurrence. And a prospective trial now in the US is assessing this question. For example, is patients with 1 to 3 positive nodes and a low 21 gene recurrence score on Oncotype DX are randomized to comprehensive regional nodal radiotherapy or not. So if this study eventually is conducted and shows that there is no benefit, then we would again carve out a group of patients that don't need radiotherapy based on the genomic classifier that puts them in the low risk. The other question that we're asking is, can we even eliminate breast radiotherapy after breast conserving surgery, which of course is something we do routinely. And several studies also have shown that the risk of recurrence in the breast is actually less for patients that have low genomic profiling. However, most of the data we have is with radiotherapy, because we've given radiotherapy to all these clinical trials that we take tumors and assess with genomic classifiers. So again, as a result of that, though, several prospective studies have been designed to actually ask the question, if we select patients based on genomic profiling as a low risk, can we observe them after breast conserving surgery and not do radiotherapy? So there have been some single-arm trials doing that, but also randomized trials. And one of it is the one that we conduct in the US at our research group, the NRG Oncology. It's called DEBRA or BR007 trial. And this trial is a large trial comparing breast radiotherapy versus no breast radiotherapy for patients that get breast conservation and have a low 21G recurrence score under 18. So that's an important part because, again, if that shows that there is no difference, we can avoid radiotherapy for these patients. But all these genomic classifiers are prognostic of risk of loco-regional recurrence. In other words, assess how big is the risk of loco-regional recurrence. And if it's low, we say maybe we can avoid radiotherapy. But the holy grail, so to speak, is to find genomic classifiers that predict whether you benefit from radiotherapy or not. And that's a different question. And now we have some evidence from a couple data sets, and one that was presented at the San Antonio meeting this past month ago, that there is a signature called the polar signature that in 3 studies and a meta-analysis of the three studies has shown actually to predict benefit from radiotherapy. So if you're low risk on the signature, you have very low risk whether you have radiotherapy or not. If you're high risk on the signature, you have low risk if you receive radiotherapy, but you have very high risk when you don't. So that's a perfect biomarker because it tells us that not only low-risk patients have low risk by definition, but also don't benefit from radiotherapy. So it strengthens the argument of not giving radiotherapy to the patient. And of course, this signature needs to be validated further in other data sets, but it's very promising, and it was exciting to see the data in San Antonio.